And now we come to the next batsman, none other than Dr. Sandeep. In fact, Sandeep is a teacher par excellence, excellent phacosurgeon. In fact, he's the one whose waiting room is always frequented by people from literary world and Bollywood. And it's my proud privilege to present to you this guy who always aims to get hit on the bullseye in every patient of his. To you, Sandeep.
Thank you for the opportunity, Suhas. I don't know whether I'm worthy of saying what the topic says, but I'll try to give my 100% as far as this talk is concerned. Good afternoon to all of you and welcome to this show. I know it's lunchtime and I am thankful to you for attending. Now, we all know that cataract surgeries are becoming increasingly refractive procedures. In fact, cataract surgery is the most often discussed surgery on breakfast table. This has been proven that this surgery is something which everybody is aware of. And patients are also aware that their friends or neighbors got operated and now they don't need to wear glasses anymore. So these patients, when they come to us, they are already aware that this is possible. And many of them require it for their professional needs. Also, many of these so-called young retired people still want to be active in life. They're not retired from life and they want to pursue so many activities which require them not to wear glasses. So there's no way you or anyone in this audience can escape this problem. Now, first of all, when you plan for these surgeries, you should be able to know whether your patient is capable of a 6/6. So a careful slit lamp examination of the cornea to see whether it is transparent enough, or are there any scars from previous infections or a previous keratorefractive procedure. Look at the anterior chamber and iris to look for signs of inflammation. Look at the lens itself, whether there is pseudo-exfoliation, is it a posterior polar cataract, is the lens decentered or subluxated. Look at the pupil for its size, look at for its centrality and for its circular shape. Look at the tear film. Remember, the light bends at the air-tear interface and 75% of the refraction happens there. So if you got to give 6/6, your tear film has to be good. Look at the lids, look for signs of meibomian gland dysfunction. Look at the cornea, see whether the patient is aqueous deficient. Do tests to verify for tear volume and tear film stability. So you need to do a T-butt and a Schirmer's in almost every case. Look at the fundus. Very often behind the dense cataract there are pathologies which can be easily missed out. And now coming to the most important thing, corneal topography. If today you are planning to make your patient emetropic, no ophthalmic surgeon can overlook a corneal topographer. Now there are so many uses of the corneal topographer, but with respect to cataract surgery, there are 5 things that I'd like all of you to remember. 1, see whether your cornea is prolate or oblate. Look at the astigmatism. Is it regular, irregular? Is it symmetrical, asymmetrical? Look at the higher order aberrations on the Zernicke polynomials. In particularly, look at the spherical aberration and the vertical coma. And look at the pupillometry. Many of the topographers have a dynamic pupillometry, so are able to get the size of the mesopic and scotopic pupil. Now, in this Zernicke polynomials, I don't want to go in details and explain mathematics, but 2 things you need to look for. The Z40 spherical aberration, which as far as possible should not be greater than 0.4, at the most 0.5, especially when you're doing presbyopia correcting IOLs. And the Z3-1 of the vertical coma, this should never be more than 0.35, especially if you're planning some such special IOL. Now I want to illustrate this with 2 simple examples. Now this is a cornea which is highly prolate, as you can see. And if you look at the Zernicke polynomial, his spherical aberration is 0.38, which is a very, very good value for a presbyopic correcting IOL. On the other hand, look at this lady. She has got asymmetrical astigmatism, but note the cornea, flatter in the center, steeper in the periphery. This is definitely an oblate cornea. Look at the Zernicke values. Z40 is 1.179, almost as if she has had a LASIK procedure, which is not. And her coma is 0.9. Now this is not a patient who is an ideal candidate for that. I now perform an OCT in almost all my cataract patients. You never know when you might have a patient with an epiretinal membrane and you are promising him a multifocal lens. You need to be on your guard. Very often the patient's intraocular pressure is very normal, 15, but yet the OCT may show signs of a reduced RNFL thickness. There may be a subtle diabetic macular edema. There may be a small macular hole due to vitreomacular traction, not to mention the large pigment epithelial detachments and the AMD, which very often these patients are associated with. Do the specular microscopy in all the cases. As Anaka rightly said, you need to know how soon is your patient going to recover from the surgery. Now coming to the IOL power itself, the most important thing is precise data acquisition and appropriate IOL power formula selection. In data acquisition, formerly we used to only collect the actual length and the keratometry, and we used to put in the SRK, SRK2 and the SRKT formulas. But if you want to be more precise, if you want to develop or give emetropia, you need to measure the anterior chamber depth from the epithelium to the anterior lens surface. You need to look at the lens thickness and the white to white diameter. Sometimes hypermature cataracts come and an optical biometer cannot be used, in which case we need to use an ultrasound. Now don't accept the value whatever your optometrist gives you. Look at the scan values again. As you can see, the first scan on the left, it's not the proper retinal spike. The one on the second and third are, but look at the second again. Because of the hypermature cataract, there is an echo within the lens itself, and the lens thickness is shown as 1.444. Here you need to adjust the marker and push it to the posterior capsule. Probably the scan on the right is the best scan that you should take. And I think every single surgeon has to see the USG, especially when it is done on those cases where an optical biometer is not possible. When placing the instrument, the patient on the optical biometer, go from behind, see whether the head is tilted. Look whether the patient's head is naturally tilted when they come to you. Look at whether the patient is looking straight ahead. Otherwise, you will get a picture like you get on the right side. And make sure that the lateral canthus is aligned with the positioning mark on the instrument. When you get the scan, look at the Myers. The Myers should be sharp. The fovea should show the natural dip as you should. If you get a value like this, now see, the limbus has not been recognized. See the picture on the right. You'll find you'll get a wrong WTW value, and that is going to affect your IOL power, my dear friends. Sometimes subtle macular pathologies like a macular edema or a cyst may be picked up on the optical biometer itself without having to do OCT. Now there are special axial length considerations. Optical biometry can provide the entire longitudinal scan of the eye, so it can diagnose lens tilt, macular pathologies, etc. Optical biometer is far superior to ultrasound, and ultrasound is superior as compared to immersion, and immersion is better than ultrasound. And the swept source OCT based axial lengths are far superior to the PCI or the OLCR based biometers. And optical readings as obtained on the axial length readings as obtained on the optical biometers are longer than what are measured by the ultrasound, where it measures from the cornea to the internal limiting membrane, and this one goes right up to the RPE. Now several kind of instruments are available for your keratometry value, and if you have them, take your measurements on as much as you can. If you find that there is too much variation, you can use the Barrett calculator to integrate these values. Now, few considerations regarding the keratometry. Optical keratometry is always better as compared to manual and auto, because these go closer to the central zone. There's not much difference between the OCLR and the swept source, because all of them are within the 2.5 zone. Dynamic keratometry in the Varion goes to even the central 1.2, but it is of doubtful superior value as it does not get integrated into the various IOL formulae. And TK, as measured on the IOL Master 700, no financial interest there, is more useful in post-refractive surgery and post-PK eyes. As far as the anterior chamber depth and lens thickness and white to white are concerned, they enhance your value, especially when you're using non-regression and some of the later 4th and 5th generation values. They give you a more accurate, effective lens position. And optical biometers also provide you the coordinates of the visual axis, so they help you to measure the angle alpha. Now choosing data for calculation. If it's an optical biometer, you take the keratometry, you take the axial length, all the readings, and do the calculation on the same machine. But that mature cataract comes where you have taken the axial length on the ultrasound. Now be careful, don't use the optical biometric K value, because the A constant is designed with optical readings only. So if you're going to use, in a hard cataract, you're going to use the immersion, then probably take the K readings on the either on the auto K or on the manual. Choice of formula. My go-to formula in most cases are some of the regression formulas like what are available on the Barrett suite, and that is my first choice. But if I find my patient's eye is very long or very short, then I don't hesitate to look at also the values on the Haggis and the Holiday 2. And especially in those cases where there has been a refractive surgery in the first eye, it is useful to use some of the artificial intelligence-based formulas like the Hill RBF and the LEDA super formula. Be careful in recognizing and accepting the K values when the patient has had keratorefractive surgery or has keratoconus. In eyes that are very long, greater than 25.2 millimeters, you need to use the Van Gogh modification of the axial length, and this is given over here on the slide. But if you are using the Holiday 2 or if you are using the Barrett suite, then you don't need to make this adjustment at all. Astigmatism, you cannot do cataract surgery overlooking either the pre-existing astigmatism or the astigmatism that you are going to create. So you need to look at your own SI depending on your incision size and the location of your incision. Maximize the usefulness of the astigmatism by planning your incision and using your own SI. Now, if your incision is going to be less than or equal to 2.4 and you're going to sit temporal, then you can safely use a centroid value of 0.1. This is just a guidance, but it's always better to do your own this. Now, these are the two formulas which I go to. The one on the bottom, the Barrett's toric calculator, is what I use in all cases, because very often you think the astigmatism is nothing and you may be surprised that the Barrett toric calculator shows that a T2 model may be required. Personalization of your A constant is always a must. The manufacturer's guide is only an indication. You need to do at least 25 cases and put them either on the Warren Hill website, or if you have your Varion, put it in your own machine and get your own A constant right. Now, when it comes to surgery, and if you are going to do an eye where you are promising emetropia, please don't use an old knife. Use a disposable knife. It hardly costs anything nowadays, and you will be able to get the best possible wound construction. Good wound construction means good healing. Good healing means less SI. You should judiciously use your viscoelastic, as Anaka showed so beautifully. If you are going to do a hard cataract, then you need to use a good OVD. This is the time when you will put the dispersive against the endothelium and put a cohesive like Helon at the bottom on the pupil. Or you can go to the ultimate soft shell where you can keep the little bit of BSS on the anterior capsule followed by the cohesive and the dispersive. This helps to do easier rexes. Always the CCC should be as regular as possible. During surgery, remove all the viscoelastic within the bag. Always sit the IOL in the bag. Tap it in so it's there. And always align the optical center of the IOL with the visual axis of the bag. When closing the eye, make sure that you have inflated the eye enough. If you do not inflate the eye and you keep it under pressure is low, watch for that posterior corneal gape, which happens. In fact, it closes only at around 40 millimeters of mercury, and then you need to burp again to make sure that your wound is closed well. And the effect of that is for you to see. This is day 1 post-op, and you can see the incisions have healed and sealed so beautifully with no edema around the wound. So the roadmap to success, it's a careful diagnostic evaluation, excellent biometry and a proper IOL selection, meticulous incision planning and neutralization of your astigmatism. You should do a safe and efficient phaco and accurately place the lens in the bag, tap it in and align it with the visual axis. Thank you so much, because see, every happy patient contributes exponentially to your practice. Remember that, and good luck to you. Thank you.
Thank you so much, Sandeep. That's a beautiful talk which has covered practically all the points. I have a question for you. When it comes to toric placement, now we all know that if you focus on getting your eyeball firm at the end of the surgery, there's always a chance that there'll be some fluid under the lens and the lens might shift a bit. So when it comes to putting a toric, what are the special precautions you take to make sure the place where you kept your toric is going to stay there?
So when it comes to a toric lens, as you very rightly said, it is absolutely mandatory that you put it bang on the visual axis. The first thing that you have to do is to remove all the viscoelastic under the IOL. From both side ports I go in and aspirate whatever little visco or fluid is there. Then as I inflate the anterior chamber and I hyperinflate it, you can see whether the IOL is moving. Most of the time, if you're using a hydrophobic acrylic lens and with a slim haptics, which are having a broad area of contact, the lens rarely moves. In fact, if you keep the pressure low, there is a chance that fluid will go in and may rotate the lens. So except in that given situation, very unlikely that a very large capsular bag, I like to keep the eye a little pressurized. In fact, I would like to keep it around 25 millimeters of mercury, at least, so that the lens will sit where it is. And post-operatively, one little thing which I would like to share with all of you is that each and every single toric that I do, as soon as I come out, I take the patient, before the next patient goes in, I see the patient on the slit lamp, because there is nothing like slit lamp to tell you the accurate alignment. Whatever digital markers you use, whatever marking lines you use, there can still be an error. But put the patient on the slit lamp, if the shift is more than 5 degrees for T4 and above, I will take the patient inside and rotate the lens. If it is more than 10 degrees for T2 and T3, I'll again take it inside.